Good morning, everybody. Welcome. Today, we're going to discuss on how to interrogate an Abbott dual chamber pacemaker. And we're going to see the different step by step, according to me, on how to interrogate a pacemaker. So, this is a patient here implanted for a paroxysmal AV block symptomatic. This is a dual chamber pacemaker, so it's a real recorded session of a given patient. So we're gonna start. The first thing here is that we're gonna look at the different, what you see on the screen. The first thing that you see in red are the alerts. So that's going to be modified in the next version of the pacemakers and defibrillators. I don't like too much the word alert like here, because usually when I interrogate a device with a programmer, I like to show the screen to the patients, and it's visual, and then you can understand, the longevity, we'll see the duration, and you will see, usually I show it when there's no problem. Of course, if there are many episodes of VT, for example, I will first have a reflection before showing it the patient the screen, but usually I show the screen, and when it's written like this alerts, that's not good, because you will not see anything but this one. So hopefully it will be modified in the next versions, and it will be called notifications. But if you click on alerts, you see here that there are a certain numbers of alerts. For example, here you see PMT has occurred. If you click on this, and you will have the possibility directly to see the episode. So if you click on PMT, for example, on this one, you will see the EGM. And so this is here a real PMT. If you start, you see initially you are ASVS, and then there are two PVCs, and then you will have the onset of a PMT. We will discuss today and probably more next week on how it works for the diagnosis of PMT, but you need 8 cycles VPAS, stable VPAS, and then after 8 cycles, there are going to be a confirmation that it is a real PMT. There will be an extension of the AV delay, so if you show it, maybe it's difficult to see it, but there is a prolongation on 1 cycle of the AV delay, and then you will look at the AA interval, the following AA interval, and you see that when you delay, you prolong the AV delay, you delay the occurrence of the VP, you also delay the occurrence of the next atrial signals. It means that there is a direct relation between the VP and AS, so it's not a sinus tachycardia. This is a real PMT. You see here it's labeled PMT, and then there is an interruption. The next AS cycle will not induce a ventricular pacing, and then after 330 milliseconds, you will have a sequence AP, VP. Whatever the details, we will rediscuss about it. But if you go out of this, so you can see that, first of all, the alerts, PMT has occurred, V%. There is also an alert in a patient. You can program or disable this alert, for example, but if there is a percentage of ventricular pacing nominally more than 40%, then you will have an alert. So you can go out of this, show the path to arrive to this. So if you want to program the alerts, you will go on parameters, alert notification, and then there are some alerts that you can or cannot disable. There are many alerts. Something important, let's consider that you don't want to see the alert on the programmer. If you disable an alert on the programmer, it will also disable the alert for the remote monitoring. So there are some alerts that you can disable, some other that you cannot disable. For example, all the technical ones, the fact that there is going to be an alert if you are in the device is in ERI, or if there is a problem of impedance, you cannot disable these alerts. Okay. So any question on this? Also, something important, on a pacemaker, it's different than on an ICD. On an ICD, when there is an alert, there can be, you can program either, it's depend on the kind of ICD, but something, a vibration of the device or the ringing of the device, depends on which kind of ICD you have. But here in a pacemaker, that's not possible. So if there is an alert, there's no vibration and no ringing for the patients. Okay, but you can have an alert, of course, with remote monitoring. Okay, so if you come back to the screen, then the next step, I will show, we have a look to the longevity. If you click on this, so if you see here, there are two values. It's 5.5 and 7.2. Does anyone know what does it correspond exactly? Why are there two values like this? You know that? Like this, it means that if you do not change anything, so no parameters, if the percentage of pacing remain the same, the duration should be around 7.2. But if for any reason the device now requires 100 of atrial and ventricular pacing, so if the percentage of pacing is now 100% for atrium and ventricle, then the duration will be 5.5. So this is different from Medtronic device that we have seen on the last sessions. Here, two values. One is 7.2 if nothing changed, and 5.5 if the percentage of atrial and ventricular pacing is 100%. Okay, you see here, there is the magnet rate, so it's 100 beats per minute. A few years ago, any students, any fellow knew any of the magnet rate at the onset of the device and at the ERI. Now, just that you know, it's 100 when it is new, and it's 85 when it is old. So something important about the magnet rate, you can, if you show us how you will program it, up, yeah, on Brady, you see here, it's a recorded session, so it's difficult to see it, but you can deprogram nominally it's battery test. It means that if you apply a magnet on the device, it will modify something, and I will explain what exactly. You can program it off. If you program it off here, it means that if you apply a magnet on the device, nothing will change. But now, if you go on the notification, you see, yes, episode settings, you see, on magnet response, nominally it is low. So that's something that you need to know. It means that if it's programmed like that, when you will apply the magnet on a device, first thing that you will have is the recording of an EGM. So without modifications of the programming. So the first step, for 6 to 10 seconds, there is a recording of the tracing like this, you see? So you see in the recorded episode, you will see a magnet episode. So if you apply a magnet on the pocket, then you will record it, and then you will modify the pacing. You will have a DO pacing 80 beats per minute. So do not be surprised if you apply a magnet on an Abbott device, there is not an immediate change in the heart rate. First of all, it will record an episode for 6 to 8 seconds, for example, and then you will have the modification of the heart rate. And that can be an advantage also. Some patients are symptomatic and nothing is recorded in the memory of the device. Remember that if you apply a magnet, then you will systematically record a tracing. So for example, if the patient is symptomatic for any reason and you don't know why, give him a magnet, and when he's symptomatic, he applies on the magnet on the device, and then you will have a recorded episode. Okay, this is something that you can program off. It means that if you program it off, whenever you will apply the magnet on, you will have a direct modification of the heart rate without recording. Okay, so the first step, you program the function of magnet on off and on or off, And once you are programming it on or off, you can change either with recording or without recording of an EGM. So if we come back here, something very, very, very important also. You see, it is green and there is a longevity estimation. You will have a longevity estimation only if you have entered inside the device the date of implantations. So if you click here on the guy on the top here, this is something here, you see, you need to enter this information. Because if you don't enter this information, then the judge will remain green all along the time up to the ERI. And the estimation will be more than 5 years. So remember, anytime you interrogate a device, if it is green, it means that probably the device is not old and you have a lot of battery, but it can also mean that you have not entered this information and therefore it will remain green all along the life of the device. Okay, so something very important in Abbott device, at the time of implantation, you need to enter the day of implantation, because if not, it will not be in capacity of calculating the longevity. Of course, you will have a value of voltage, but the longevity will not be calculated. Anything else to say on this? No. Okay, so now we'll have a look to the information about the leads. The first thing that you will look is the lead impedance. If you click on it. So for the lead impedance, you see that you have the last 7 values. These impedances are measured every 23 hours. 23 hours. It means that the hours of measurements will change every day by 1 hour. So it's different, for example, in biotronic or Medtronic device, when you know exactly at which time of the day it will be measured, not in Abbott devices, since it's every 23 hours. So you see the exact value of the last 7 measurements, and you see also the other dots are 1 dot by week. It's the median value for it. So what you look here is that these values are normal and are completely stable at the level of the atrial leads, and the same for the ventricle. If you show us the ventricle, please. Up. Yes, it's exactly the same. The values are normal and are stable. What you show here is the ventricular lead monitoring. The monitor, you can program it. Yes, I'm sorry, because it's a real recording, so you cannot change here. But you can ask that there is a shift from if a value is abnormal out of the limit. It's the same in Medtronic devices. You can ask the device to systematically shift from bipolar to unipolar pacing if bipolar impedance is abnormal and the unipolar is normal. So now if you go on the sensing, please, up, if you click on it. So you see the dots that you see here, there is a trend and a decrease in the amplitude of sensing at the level of the atrial leads. I don't know exactly which who is this patient, but you see here that there is a decrease in the value of the sensing. Sensing, the same, a sensing test is performed every 23 hours. And it is measured on five atrial sense bits, and you can see the EGM. You see that with Abbott devices, there are many EGM. This one, you cannot disable it. You will have systematically the EGM of the last test for the sensing. So this is the one performed the day before. And you can see exactly the signal. So you see here, it's pretty stable, and the mean value is 2.4. So if you show it for the ventricle now, the same, you see, if you click on it, you see the last value, and with the measurements of, it's based on 5 measurements. They don't have to be consecutive for the measurements. Something important, to perform the sensing, the automatic sensing test, there's absolutely no modification of the pacing rates or of the AV delay. So you need to be sensed to see something. And if you are permanently paced, of course, you will not have any kind of measurements. And you will not try to modify either the rate or the AV delay to be in capacity to test the device in terms of sensitivity. If you close it. Now the capture. So the thresholds. For the threshold, exactly the same. You will see the EGM. So here is the actual test. This is something, sometimes in a tracing, you see this marker, APP. When you perform the automatic test at the level of the atrium, there is one amplitude to test, and then there is systematically a backup pacing with high amplitude. So what it means here is that first you pace the atrium and then you pace with backup pacing. So when you see this marker APP, it means that the device is, at the time of you see this marker, is performing the test of atrial threshold, okay? And once more, it will not try to modify the heart rate at the level of the atrium. And now if you close it, you see the slight increase in the threshold. Maybe there is something wrong in this lead, and you see the decrease in the amplitude of the signals and the increase in the threshold. So if you close it and you show us the level of
sorry to interrupt, Pierre, just for the atrial threshold, it can still do the test even if it's sensing. Yes. It doesn't really modify the base rate, so the patient won't feel any rate increasing, but it will try to make some pacing very space in the time so that the patient doesn't feel it, but sometimes you can see a shorter interval with APP, and then you have a sense again. It just is spacing, but it doesn't modify the rate of the patient.
Yes, exactly. Let's consider you are atrial sensing. If you want to test, if you have an automatic test, in the other devices, it will systematically increase the rate, and then you will have successive AP to know if you are capturing. In Abbott, it's a bit different. You will have AS, and sometimes one APP, and then AS, another APP. It will progressively decrease the amplitude, but the APP will not be consecutive. That's why sometimes some tracing are a bit strange. If you record something at the time of the atrial threshold, you will be surprised to see AS, and sometimes APP, AS, APP, not consecutive APP. Okay, so if you come back to the ventricle now, so that's something, okay. And remember, when you test at the level of the atrium, systematically, if you capture or not, you will have two pacing stimuli, the test and the backup pacing, systematically at the level of the atrium. At the level of the ventricle, it's a bit different. You will test with one amplitude, and if you capture, there's no backup pacing. But if at one time like this, you see the loss of capture, then you will see the marker VPP. It means that you pace. It was not if you have not captured the myocardium, and then you have a backup ventricular pacing. And something here at the level of the ventricle, it will not modify the pacing rate. It means that if, for example, in an ICD, many patients are programmed in VVI 30 beats per minute, not to pace, just to respect the spontaneous activation. If the patient is like this, programmed at VVI 30 beats per minute, and if he has a spontaneous rhythm, then you will not have the possibility to test the thresholds at the level of the ventricle. Okay? So if you close. So now you see here are the main parameters, okay? So main parameters, okay? And then if you click on new EGM, something important, when you click on this, you see that you just see the last episodes that have been recorded from the last session, either with a programmer or with remote monitoring. That's important. Let's consider there is a complete interrogation with remote monitoring. if then you perform an interrogation with a programmer, you will only see the episode from the time of the remote monitoring, okay? But you have the possibility to see all episodes. So every episode that has not been deleted. So you will write it like this, include all episodes, and then you will see all episodes. So remember, so you see everything. There is a question about should we delete all the episodes? So remember one thing. If a patient comes with episodes, can you show us how to do it? If you want to wrap up, and then here it's not clear, but you can delete the episodes. So once more, it's a recording session, so you cannot see all the different items. But at this time, let's say you have finished your interrogations, and there are two things that you can delete. The first one are the statistics. If you delete the statistics, then every statistics will come back to zero. And then if you don't, these statistics will be less interesting. For example, if you modify something and if you want to see the impact on the percentage of pacing at the level of the atrium or at the level of the ventricle, you need every time you do the interrogation to delay the statistics so it comes back to zero and you see the impact of changing the parameter on the percentage of pacing. The second step is that you can consider deleting the episodes. If you delay the episode, nobody will have the possibility to re-see the episode. Of course, there are some protection. First, the episodes are still in the data bank with remote monitoring. So if for example, I delete an episode, then I can re-see this episode on remote monitoring. If you delete the episode with one programmer, remember that the session remains inside the programmer. So you can re-interrogate, but you will have to re-interrogate this programmer. Okay, so if you delay the episode and then you want to interrogate this device with another programmer, then you will not have the possibility to re-see the episode. That's something important because sometimes with fellow or interns in France are deleting the episode, and we are not very happy if we cannot re-see the episode to check if it was true or not. Okay, so if you come back to the episodes. So you see here, there are episodes of PMT. There is one episode, for example, of automatic mode switch. If you come back, okay. This is something pretty different for Abbott devices, the way it works, the automatic mode switch. It's very, very particular in Abbott, and we will discuss about it next week. But you see here, onset probably of a real atrial arrhythmia, and then you will see the marker automatic mode switch. The trigger, you see, the trigger means that it is triggering the recording of the episode in the memory of the devices. Okay, so and you see that this is a very short episode. We will see it in the statistics. Okay, you can close it. Are there any questions? Nope.
Just one little one. How do we reset the statistics? Because you've shown us how to delete the episodes.
If you remember, ask me again. At the end, we will go on the simulator, and we will show you. Here, it's not possible because it is a recorded one, but this is where you should click, and I will show you after. Okay. Do not forget to re-ask this question at the end of the session. Okay.
Okay. Thank you.
Okay. So if you come back to the here, yes, the EGM, then the statistics. So the first thing are the rates. And you see here, well, it's pretty simple. Yes, you see time at maximal track rate. You see here, less than 1%. That's an information I always have a look, because sometimes when this percentage is very high, let's say 20, 30%, it may be a problem of blank atrial flutter or PMT that has not been diagnosed or anything. When the percentage is high here, always I have in my mind that maybe it could be a problem. So that's something that I have systematic look at. Okay. Here you see the statistic in yellow. You see the dot yellow means that this is the percentage of pacing that you would have if the sensor was programmed on. In this patient, it's programmed DDD, not DDDR. So in yellow, you will see if you had programmed DDDR, you see you will have more atrial pacing at this rate, and you see the curve if the sensor has been programmed. Sometimes it's interesting to know if, for example, there is chronotopic incompetency. You have the information what would have been the rate of pacing if the rate adaptive function had been programmed on. Okay. So anything else here? Nope. You see the percentage of ASVP, ASVS, and also yes, something important. The percentage of PVC can be in some patient an interesting information. So if you click now on conduction, the same with the sensor. If the VIP algorithm is programmed, these information are very interesting. You will see the duration of the AV delay of the PR interval, so spontaneous or pace interval in a given patient. So in a patient, when I want to decrease the percentage of ventricular pacing, this is a screen I have a look to know exactly what is the PR interval or the AV delay. If you click now on mode switch, on the mode switch, you have the number of episodes. Here in this patient, there are very, very, very few numbers, so it's nearly 0% of the time. The information, yes, the duration. You see that the duration of the episodes are very short. So it's an interesting information. And most of the episodes are less than 1 minute. That's the AGM that you have seen. You see it was very short episode of atrial fibrillation, less than 30 milliseconds. You can see also the rate at the level of the ventricle, if it is controlled or not. You will see it's interesting. If you click on it, if you come back to the previous screen, yeah, you see if you click on AMS log, so if you click on it, you have the possibility to click on duration, and you will rank the episode according to the duration. Sometimes it's interesting to know the longer episode, the shorter, yes. So you see here that every time it was very short episode of atrial fibrillation between something like around 10 seconds. Okay. Anything else? Nope. The exercise and activity. So that's something a bit special. First, the information that is important is the one in pink. No, pink. No, comment dire rose? In rose. I don't know the word in English, but this one, this curve, it means that with this, you will know the amount of time the patient is considered as active. So the sensor will say there has been motion or exercise. And this is the one I have a look to know exactly if the patient is active or not. In green, it's a bit more difficult to explain, but the device, if you want to have this screen, you need to enter. If you click on the guy up here, you need you need to enter the date of birth of the patient. You see here, you need the birth date of the patient, because then with the birth date, it will calculate the theoretical maximal heart rate, and then it will give you the information on the percentage of time where you were close to this heart rate, or at 60 to 80% of this maximal theoretical heart rate. So you need to enter the date of birth of the patient. If you understand well, clearly in Abbott devices, you need to enter the information of the patient. You need to do it. So the date of birth and the date of implantation, if you want to have all these informations. Any question on this? No, if you close. And that's about it about this screen. Are there any question here? No? Okay. Up if you stop sharing your screen. So today is mainly about interrogation, not about programming, but we need to connect the simulator. So we have 5 minutes to do it. And I will show you just one thing. Abbott is a bit specific because there is no specific mode to decrease the amount of ventricular pacing. The only thing that you have will be the VIP, ventricular entrancing preference. It is an algorithm which is made to decrease the amount of right ventricular pacing by prolonging on a few beats the AV delay. So it's a AV delay hysteresis. You see, so this patient initially on the tracing, you see is APVP, he has been implanted for sinus node dysfunction. So if he is 100% of the time with ventricular pacing, that's not how he should be programmed. Probably that's not the results that you expect. So in this patient, you will program the VIP, and the idea is that you will prolong the AV delay on a few beats. So next time I will show you how you program it. There are some parameters that you can program. You can program the number of cycles with prolongation of the AV delay. It's 1, 2, or 3. You can program also the interval of search for entrancing conduction from 30 seconds to 30 minutes. It means that if you program 30 seconds, every 30 seconds, you will prolong the AV delay to know if there is an entrancing conduction. And the third parameters that you can program is the extent, the duration of the extent of the AV delay. Whatever you program, the AV delay can never be more than 450 milliseconds. Okay, so the AV delay plus the extent at the end, it cannot be more than 450 milliseconds. So here it works perfectly. And you see here what happens if, for example, there is no entrancing conduction. You see here APVP 200 milliseconds, and on 1, 2, 3 bits. So you can program 1, 2, or 3. Nominally, it's 1. And there is a prolongation of 200 milliseconds, but you see that there is no entrancing conduction. So you come back to the program AV delay. And then, according to the duration, every 30 seconds up to every 30 minutes, and nominally it's 1 minute, you will redo these processes to know if there is an entrancing conduction. One thing important is that this will not be performed if the heart rate is more than 110 beats per minute. That's something very important, because if you prolong the AV delay, one of the risks is that, you remember the 2-to-1 point is based on the sum of AV delay and PVARP. So if you have an AV delay of 450 milliseconds during exercise, you may encounter 2-to-1 block. So that's why this algorithm will work up to a rate of 110 bits per minute. Just this tracing, the time that they are ready for the simulator. And this is something, so it's called TRE, it's PMT in French, TRE, PMT in English. That's something specific also in Abbott devices, is that you have the possibility to record an EGM if the device diagnoses a PMT. It's nominally off. So nominally it's off, so you will not see this kind of EGM. But if you program it on, then you have the possibility to see the episode of PMT. And you see here a patient with APVP, 200 milliseconds. That's the nominal value for the AV delay, paced AV delay, 200 milliseconds, 200 milliseconds. And what you see here, VIP. So it will try to find an entrancing conduction, and it will prolong here, you see 100 milliseconds on 1 bit. The problem is that two limitations with long AV delay. The first one is the 2-to-1 block during exercise, and the second one is the risk of PMT. You increase the duration of the AV delay on 1 bit, and in this patient, it will favor the retrograde conduction. So increase. So if you remember the AGM that I've shown you on the programmer, there was a PMT because there was a PVC, two PVCs. Okay, so specific problem, desynchrony between ventricle and atrium, PVC, desynchrony, and then PMT. The problem here is that there is creation of a PMT just by prolonging the AV delay without a need for a PVC or a premature atrial contraction, just prolongation. And this favors the retrograde conduction. And you see cycles VPAS, VPAS, VPAS. As I explained before, you see here the AV delay is 200 milliseconds. There is on one bit a prolongation of 50 milliseconds of the AV delay. So you delay the ventricular pacing, and then it's not exactly like this, but let's explain it like that. And you see that if you delay the VP, you also delay the atrial sensing. The atrial sensing cycles were 500 milliseconds, and now it's 540. It means that if you delay the ventricle, you also delay the atrial signal. It means that the atrial signals is related to the ventricular pacing, so it's a PMT. If it's a sinus tachycardia, if you prolong the AV delay, you will not change the atrial cycle. It will remain exactly the same. So this is a proof that this is a PMT. Here it will be written PMT in American tracing, here it's going to be written trigger, and then interruption, no tracking of this atrial sensing with ventricular pacing. And then after 330 milliseconds, AP, VP, end of the tachycardia. So it was clearly a PMT. So I'll show you this tracing just to explain you two things. First, that if you want to see the episode of PMT, and I think that's very important, interesting in many cases, you need to program it. The question is that then you will have to define a priority, because if you record PMT, the thing that you don't want is not to record, for example, automatic mode switch or this kind of thing. So you need to define a priority. But I think it's important, I will program it as low to see at least one episode of PMT to check if it is a real PMT and what is the reason for using this PMT. And the second thing about the VIP, it means that in this patient, just prolonging the AV delay induces a PMT. So this patient had many episodes of PMT recorded in the memory. And of course, in this patient, it seems to be in AV block. There is absolutely no reason to program the VIP. So you can disable the VIP function, and then you will considerably decrease the risk of PMT. One thing also is that if there is an episode of PMT, you need to program a PVARP longer than the retrograde conduction time. So you need, in this patient, you will disable the VIP, but you will also prolong the PVARP to be longer than the retrograde conduction. It's okay. Are you ready for the simulator? Okay, so that's now a simulator. And the thing that, first of all, so this is something, when you interrogate a device, you see the different channels here. Remember that what you see here does not systematically correspond to the channels that are recorded. You can change these channels to understand the tracing that you see. So I will say that, you see, you have different possibilities. On top, usually I will connect the ECG. And then if you click, go out of this, please, up. Okay, so you see here, it's program V bipolar ASense. So that's not the way I will program it. If you click on this, okay. The two channels that I like to see are ASense amp and VSense amp, okay? The bipolar, for example, if you program bipolar, this is the raw signal, R-A-W in English. You see, it means not filtered signals, the bipolar. If you click ASense amp or VSense amp, this is the working channel of the device. It means the device will work with this channel. So if you want to measure the amplitude or this kind of thing, this is the channel that you want to see. ASense amp or VSense amp. If you program V bipolar, this is an unfiltered channel. So V-sense amp is filtered and bipolar is not. This is the raw signal, okay? So usually I program V-sense amp and A-sense amp. Something important also, if you program on a programmer this kind A-sense amp and V-sense amp, this is going to be the same on the next patient, whatever the patient. If he has the same device, you will see also the same channels, okay? So remember, if you program it, it's going to be the same in the next patients. Okay, what could I say on this? Yes, there is a camera. Sometimes during the interrogation, there is something interesting. If you click on this, then it will record for 30 seconds. Let's consider during the interrogation, you see something, an arrhythmia or something like that. You click on the camera and then you will have 30 seconds of this. Okay. Anything else to say? Yeah, the calipers, that's what you can measure are the time. You know, they are horizontal calipers. You can change it, you see, and then you can measure the time. But there is no calipers for the amplitude of the signals. If you want to know the amplitude of the signals, then you need to calculate it. You will know the gain, and then you will have to measure exactly. But there is no caliper for measuring the amplitude of the signals. Okay, so as I said, this is different. What you see here, and if you go to parameters, episode settings, then you can modify that the EGM, the stored EGM, the one who are stored or recorded, and then you can select it. So once more, remember one thing, you can program up to 3 channels. I think that for a dual chamber pacemaker, I usually program 2 channels for the stored EGM, because the more channels, the less duration of the episode you will have in the memories. If you just program 1 channel, you may have at the end 14 minutes of tracing. If you program 2 channels, it's going to be between 7 and 8 minutes of recording. If you program 3 channels, it's going to be something like 5 minutes. So the more channel, the less duration of the episode. Usually in a dual chamber pacemaker, I'm happy to see atrial and ventricular information. So I program 2 channels. And once more, what I want to see is the functioning, so the working channels, and the 2 working channels are the V-sense amp and A-sense amp. So for the stored EGM, that's also the same. I systematically program A-sense amp and V-sense amp. Okay, any question on this? So now, if you're going to test, so we have interrogated all the device, and now we want to test the impedance, the sensing, and the capture. Obviously, I do not redo systematically the impedance, so you can do it separately. Let's start for the sensing, for example. Well, okay, that's the impedance. You can redo the measurements, update values. Then you can do it for the test. If you do it like this, that's the way I do it usually, but you will have different measure. You will need to redo the test for the atrium and the ventricle. If you do it for the atrium, you see, you only see the information at the level of the atrium, and then you can check and you will see the amplitude. Okay, close it, please. Click on sense, please, on atrium. There is a method, 2 methods. You see, if you click on it, you can select for the sensing test, automatic or increment. Usually, and 100% of the time, we do it automatic measurements. Increment was the old versions, and we don't do it anymore. If you close it, okay, close it, please. If you can show us how you can have all the tests in the same, if you click on test, you see, if you click on test, and if you click on, yes, if you click on the 4, well, update all, then you will have all 4 measurements in the same time, you see? You will have both atrial sensing and ventricular sensing at the same time, but that's a detail. If you close it, usually I start from this screen and I do first atrial sensing and then ventricular sensing. Then I will do it for the capture at the level of the atrium. if you click on it. No, first the ventricle, please. If you can start with the ventricle. Yes. Something here, you have two possibilities. If you click on options, it can be auto capture or decrement. Decrement, it means that it will decrease like a typical threshold. You will decrease step by step the amplitude of pacing, but you can also the device to show you the auto capture test. If you do it, for example, okay, if you change, maybe you may change the rate, but okay. Yeah, but that's a simulator. I don't think it. Yes, first there is a configuration. There is an auto capture setup. That's what you see here. So during the setup, there is systematically ventricular pacing and then backup pacing. And then I don't know if we'll show you. It's a simulator, so I don't know if it will work. Then it will perform the test by decreasing step by step the amplitude of pacing. Okay. Okay. Okay, yes, now this is the test that is performed. Okay, so go out of this. Sorry, say now you see the test. Okay, it will decrease, decrease, decrease. So it's a simulator. So, and then you see the loss of capture, and then it will increase progressively the rate. What I want to explain to you is that, according to me, if you want to know if it works correctly, the auto capture, I think it's important to do it this way during the interrogation. That's the way I do, at least. If you close it, close, close. Okay, and then you can do the same for the atrium, whatever. Okay, any question?
So I think in this patient, the cap confirm was switched off. So you forced the programmer to do this test, and then it first wanted to calibrate, and then it did the test, and then it asks you, do you want to program the cap confirm in this patient?
Exactly.
So it's a bit slow the first time, but the other times it will be a bit faster.
It will be faster. Mark, anything to add for Abbott devices?
No, I think it's quite complete.
Are there any questions? Yes, if you want to come back, if you can show us, if you want to come back, yes, this is the question. You see, here, you wrap up overview, clear diagnosis, and then you have the possibility to click only the diagnosis or the episodes, or both. Once more, if you delete the episodes, then you will not have the possibility to re-interrogate the device and re-see this episode. But the session has been saved on the programmer. You know, the programmer has been changed in Abbott devices. It is called Merlin. The Merlin 1, it was very easy if you have recorded a session to re-see the episode. In Merlin 2, you will have to ask the rep of Abbott on how to see the tracing. It's not as easy that it was before. Remember? So once more, you interrogate the device. For any reason, you delete the episodes. You can still re-see this episode on the programmer where you have done the interrogation, but on the Merlin 2, so the new programmers, you need to ask someone from Abbott to how to see the tracing, because it's a bit more difficult. Okay. And usually, it's always better if you delete at one time. If the episodes have been saved and have been seen, usually I delete the episode, because at the end you will have many more. It will take a lot of room inside the memory, and that can be a problem, particularly in Abbott devices. Any questions?